This is an MS Views Now program. My name, for those that don't know, is Stuart Schultz. I'm president and founder of MS Views and News. And tonight we are sponsored by Genentech and Sanofi, and they are doing their best to help us to provide these programs. Our guest tonight, as you all know, that's why you're here, right, is Dr. Aaron Boster. And Dr. Boster is the founder of the Boster MS Center in Columbus, Ohio. Tonight, he will be speaking about the concept of smoldering MS, the new biomarkers, neurofilament light chain, BTK inhibitors. I don't know, maybe he'll even say something about a new blood test that's out that's also known as a biomarker. But let's get this program started. Dr. Boster is going to speak for 30 minutes, and then we will go to Q&A. Okay, Dr. Boster, take it away.
Stuart, thank you very much for having me tonight. It's great to be back. I see that there's 58 souls that have joined us, 59 this evening. Thank you all for taking some time out of your night to up your game and to speak with me. And today I want to address a question that I was posed maybe about a week or two ago in clinic. Someone said, "Hey, Dr. Boster, what has you excited about the future?" And that was a really interesting question to be asked by a family in a clinic room. And as I reflected on it, there's really three things that has me kind of riled up and excited. The first thing is a change in philosophy. The second thing is the development of a new biomarker. And the third is the development of a new class of medication. And so that's what I was hopeful that we could speak about tonight. These three things, this philosophical change, this new tool, this new biomarker, and these new therapies that are being developed. And that's what's got me kind of riled up. For those of you that don't know me, my name's Aaron Boster. As Stuart mentioned, I'm the founder of the Boster Center for Multiple Sclerosis in northern Columbus, Ohio. We care for families impacted by MS. If you haven't met me online before, howdy hi. I decided to be an MS doc when I was 12, not because my Uncle Mark had MS. He had MS since my earliest memory. But I remember rather vividly my mother and grandmother being really, really sad and upset while my uncle was in the other room. And they were upset because they couldn't get a hold of their doctor and they were scared. And this predates an era of medicines. It actually predates the interwebs. So I'm sharing how old I am. And I told my mom at age 12 that I was going to learn to do it better, that I would learn to take care of people better than the guys that were taking care of my uncle. Now, truth be told, I had no idea what I was telling my mom. I didn't know that I'd go to 27 years of school or that I would be bald before I finished my training. I just knew that nobody should make my family feel that scared and that alone. And I've been rather mission-driven in my desire to help families impacted by MS. I was the weirdo in high school that said I'm going to be an MS doctor. And I had a very, very directed course. So I've now been delivering MS care for, gosh, going on almost 20 years. And it's my ongoing mission to energize, to empower, and to educate families impacted by MS. That's why I love kind of working with Stuart Schultz and MS Views and News, because these guys, as you're well aware, are on the forefront of bringing educational information right into your home. I've never been more impressed than with this organization during the global viral pandemic, when they pivoted on a dime and they didn't slow down their educational offerings at all. They just converted to doing things virtually. And so it's so nice now that we're doing hybrid programs, and I'm really, really excited to get a chance to speak with all of you tonight. So I'll talk to you for maybe about a half an hour about these things that have me excited. And then Stuart's going to jump back on the camera and we're going to open it up for a Q&A. And so there'll be an opportunity to hear from you and we can have a dialogue. So as it relates to things that have me fired up about MS, the first one is in fact philosophical. And what I mean by that is there's a paradigm shift in the way that MS neurology is thinking about multiple sclerosis. Now, when I was in med school, I was told that MS is a disease that only affects the white matter of the brain. It only affects white people, mostly just women. It doesn't cause pain. So my professors were wrong in all three things. And we've come a long way in our understanding of MS. But in the recent last few years, there's been a really important shift in the way that MS neurologists think. See, in the 90s, we really focused, almost laser focused, on things that were easy to see. So inflammation, for example, an MS attack. For example, enhancing lesions on the MRI. Now, it's not to say that enhancing lesions aren't important, because they are. That's not to say that an attack isn't important, because it most certainly is. But in focusing on that acute inflammation, we were ignoring other aspects of the disease. And I think as a result, it negatively impacted the way that we deliver care in clinic, and it negatively impacted the way that we consider research questions. So let's have an honest discussion about this paradigm shift. We are now starting to admit, to recognize, to call into the discussion the fact that in many ways, MS is a smoldering disease. Yes, there can be acute bouts of inflammation with attacks and new spots on the MRI and contrast-enhancing lesions, but the disease is much, much more than that. And so just to make that point, I'll give you an example, something that I see in clinic all the time. Someone will say, hey, my MRI hasn't changed in a couple years, and I haven't had an attack, and you're telling me that my drug's working. Well, why the hell am I having more trouble walking? And many of you on the line might resonate with it. Say, yeah, I've had a similar experience, or my loved one has had a similar experience. And unfortunately, until recently, a lot of doctors, a lot of neurologists would say something to the effect of, oh, honey, you're doing fine. Everything's okay, which kind of feels like gaslighting, because then why are things getting worse? So let me break it down this way. In the setting of multiple sclerosis, you can develop difficulty, you can develop problems or worsening from one of two ways. The first way we call RAW, R-A-W, which stands for relapse-associated worsening. And this is a situation where you have an attack, and I'll use an example of optic neuritis of the left eye. So God forbid you have an optic neuritis and your optic nerve swells and it hurts and you can't see. And then you're given steroids and some time and your vision returns, but it doesn't return all the way. So now you only see maybe 20/200, which is legally blind. You can see, but you can't really see as well as you used to. This is an example of RAW, relapse-associated worsening, because you accrued some disability from incomplete recovery from that relapse. And that's an easy thing to understand. But the reality is that's not the way most people with MS get worse. More commonly, they get worse from something called PIRA, which is P-I-R-A. That stands for progression independent from relapse activity. And so you can get worse from PIRA at the same time that you're having early disease and having episodes of RAW. Now, I don't want you to think I'm talking about two phases of the disease like we used to talk about, where, oh, you have relapses and everything's having relapses, and then you draw a line in the sand and call it secondary progressive MS, and then you slowly get worse. That's not what I'm talking about. I'm talking about as early as you care to measure the disease in the first couple years, people can get worse from MS for both of those reasons. Now, this came out in a very interesting trial. And so some of you are familiar with the OPERA trials. The OPERA trials were the way that we studied ocrelizumab, Ocrevus, which is one of the medicines used to treat MS. It's one of the B-cell depleters. We now have 4. And in the OPERA trial, they did something really clever. They went back to the trial and they looked at people that experienced relapse-associated worsening. So, they're going along, they get worse, and they don't get all the way better. And they extracted statistically that information out. And what they were left with was PIRA. They could see that people, as early as we cared to measure, like upwards of 80% of people were experiencing PIRA, progression independent from relapse activity. And so calling that into scripture, I think, is a really important thing. It's important because, number one, gosh darn it, it's honest. It's honest, and it no longer allows a doctor to sort of gaslight a patient, say, oh, honey, you're fine. Your MRI's fine. You're doing fine. Well, then why am I having trouble walking? And it also allows us to have a more informed discussion. Now, that's a discussion that I have with a family in clinic. And it's also, very importantly, a discussion of smoldering MS and changing the targets of treatment. When we had our very first MS therapy, it was 1993. So prior to 93, there were no therapies to treat MS. We now have, I count, about 27 different formulations, maybe 19 total different drugs available to treat multiple sclerosis in 2023, which is freaking awesome. That's amazing. That's a wonderful, wonderful thing. And these medicines have changed the face of multiple sclerosis for the better. All of the medicines are, in my opinion, anti-inflammatory medicines. They are primarily really, really good at shutting down new spots on the MRI, which is very important. And they're primarily really, really good at shutting down new relapses, which is very important. They also, to a lesser extent, slow disability progression. And some of them, the newer ones, probably do that better than some of the older ones, but that's not adequate. We need to do better. It's not that we need to throw out all the old medicines. I think that we need to develop new therapeutic targets. And that's why adopting this paradigm shift of smoldering MS is so darn important in the realm of research. It's my strong opinion that in order to beat multiple sclerosis, we need 3 different kinds of therapies. We need an anti-inflammatory agent. Those are the drugs that we have now. And as I'm fond of saying, I want you on the most effective disease-modifying therapy that you're comfortable taking. And that anti-inflammatory agent is extremely important. But we need, in addition, a remyelinating agent. We need something to put the plastic coating back on the wire to remyelinate from the demyelinating damage. And third, we need a neuroprotective agent. We need something to preserve the neurologic reserve. Now, humbly, we don't have a remyelinating agent that's prime time yet. And humbly, we don't have a neuroprotective agent yet, but we're working on it. And I'm really excited about this paradigm shift from laser-focused inflammation only to really opening our eyes to the concept of a smoldering disease process in progression independent from relapse activity. So that's the first thing that I'm really excited about. And I'll punctuate that with a sip of seltzer. Oh, that's good. Now, the second thing that has me really, really excited is the development of new biomarkers. So what's a biomarker? A biomarker is a test that teaches us about a human or about a disease process, which is like a surrogate. And so my favorite biomarker was made famous by probably the most well-known intergalactic space doctor ever. That's Bones McCoy. So Bones McCoy was the doctor on the Starship Enterprise. And when they would travel to unknown places and they would meet an alien, he would whip out his tricorder, right? And he'd go, damn it, Jim, they've got multiple sclerosis, right? And he would use the tricorder to diagnose what was going on. Now, I really want a tricorder. We don't have a tricorder. That's an example of a biomarker. And the reality is that in the setting of MS, we're still kind of in the Stone Ages. The number one way that we learn about you is by talking to you, because you're a you expert. So literally, we have to learn to listen and shut up and listen to how you're faring with the litmus test of life. And we can do neurological examinations, or what I call like the MS Olympics, where we're trying to examine you to look at various features of your neuroexam. There is one biomarker that we use routinely now. It's a very powerful biomarker to help us diagnose MS and to monitor disease activity, and that's the MRI machine. So we have really sped up our ability to diagnose MS by getting an MRI. We can diagnose MS over 3 times faster than we used to because we can see changes on the MRI and not wait for someone to have more disease activity. And that's a godsend. That's a great use of a biomarker. When you have MS, we use the MRI, amongst other tools, to see if our drugs are working. Again, those anti-inflammatory drugs, to see if you're having new brain damage on your head. But the MRI is not the end-all be-all. It's a picture of structure. So if I took a picture of your house, I don't know if you're eating dinner or not. I don't know if you're having an argument or not. I don't know if the sink's running. I don't know anything about the function of your house. I just know something about the structure. And that's kind of like what an MRI does. So we really would benefit from a biomarker that taught us more about the disease. And there are other autoimmune conditions that have really great biomarkers, like rheumatoid arthritis has a rheumatoid factor. And so you can draw a rheumatoid factor, that's a lab, a blood test, and it teaches you about the rheumatoid arthritis. It's like a tricorder. And there is ongoing research studying biomarkers. Now, none of them are prime time, but there's one that appears to be getting really close to being prime time, and it's the one that has me the most excited. And it's called neurofilament light chain. So that's a mouthful. Neurofilament light chain. So let me tell you a little bit about neurofilament light chain. So I'm going to use a prop. So I've got this wire here, and we're going to say that this wire is part of a neuron. So the neuron is the cell in the brain, and there's a long sticky outy part of the neuron called the axon. And when a neuron communicates with another neuron, it sends an electrical message down the axon, right? And on the outside of the axon is the myelin. And so when MS damages this, and it strips off the myelin, it can literally crack the axon. The axon can break. And then all the stuff inside the axon leaks out. And it leaks out into the spinal fluid, and it makes its way into the bloodstream. Well, inside that axon are cytoskeletal elements. What's that in English, Aaron? It's these chains that provide structure to the axon. And there are neurofilament heavy chains, neurofilament medium chains, and neurofilament light chains. And when you crack the axon, all these neurofilaments are spilled into the spinal fluid, and then they float into the bloodstream. And it turns out that the higher the level of neurofilament light chain, the more axonal damage. And if you measure that in the spinal fluid, it's very, very sensitive. The problem is, though, most red-blooded Americans are not desirous of having someone stick a needle in their back every once in a while to check neurofilament light chain. Well, something really special happened a couple years back because we realized we could test it in the blood. Now, in the blood, it's like 40 times lower. It's a much lower amount, but we can still test for it. And what we started to uncover is really exciting. So if you look at the United States military, and they study people in the military, they get blood tests on everybody, and there's people in the military that have multiple sclerosis. And when they go back and they look at blood samples before they got MS, and then after they got MS, what they find is really interesting because they check neurofilament light chain, and they find that before they have MS, their neurofilament light chain is elevated compared to other people in the military. If you look at people with MS that are not on therapy, you'll see that their neurofilament light chain is really high. And when you put people with MS on a medicine, on a disease-modifying therapy, the neurofilament light chain lowers. And if you put them on a more effective therapy, it lowers more. And that's really, really cool. It's a biomarker potentially that could give us insight into how somebody's doing. Now, before you get all excited, it's not prime time yet. Right now, it's very successfully being used in research to look at groups of people. So a group of people with MS on one drug versus a group of people with MS on another drug. And in groups, it's really turning out to be very, very informative. But we're not good enough yet to do it in an individual human. That's not working out just yet. And there's a lot of reasons for that I'll talk about for a few minutes. So as you age, you have neurodegeneration just because you get older. And so your neurofilament light chain goes up. A larger body habitus can cause neurofilament light chain to go up. A smaller blood volume can cause neurofilament light chain to go up. Any other neurological condition can cause neurofilament light chain to go up. So traumatic brain injury, stroke, ALS, they can all cause neurofilament light chain to go up. It's not specific for multiple sclerosis. And so the challenge right now is to come up with control levels, like what's the baseline level? And the baseline level is probably going to have a lot to do with the person's age, and it might have to do with their body weight and some other things, so we know what the baseline is to compare. And it's not specific. The other thing that I have to point out is that the neurofilament light chain doesn't measure every single aspect of MS disease activity. It seems to correlate best with inflammatory activity. So it correlates really well predicting a relapse, or it correlates with new spots and things like that. But the answer, if you will, the all-singing, all-knowing, all-dancing biomarker is probably going to be multiple different blood tests like neurofilament light chain. And so at this point, whereas it's not prime time, we're getting really, really close. And I'm very excited about the prospect, maybe in the next couple of years even, that we would be able to order some blood and get a sense of how we're doing with MS. And that really reminds me of the tricorder that Bones McCoy used to have. So the second thing that has me really excited is the idea that we're developing a brand new biomarker. Another sip of seltzer. Now, the third thing that has me really excited is a new class of medication which is being studied to treat multiple sclerosis. I bluntly don't get very excited about Me Too drugs. So if we have a drug on the market and another company makes one that's very similar, that's great because more options is wonderful, but it's not transformative. It doesn't further the field. So as an example, if we have a pill that works in a certain way and we come up with another pill that is in the same class, okay, well, great. But that doesn't move the field forward. It doesn't get us closer to being able to do more. And on the flip side, I get super excited when there are new therapies brought to market that really change the options for treating MS. So remember I said when I was in med school, all we had were the interferons and Copaxone back then. And then later we got drugs like Tysabri. But we were told back then that MS is only a T-cell disease, which is false. Now it turns out that the B cells, which are also part of the immune system, are very involved in MS. And as many of you on the call are aware, there's now a bunch of medicines that literally target B cells. So when the B cell therapies first came out, that was transformative. That brought something new to the market, which allowed us to attack MS in a brand new way. And right now, in multiple phase 3 trials, multiple MS companies, manufacturers are aggressively developing a new class of medicine that brings not one, but 2, maybe 3 new things to the table that we haven't been able to do before. What am I talking about? I'm talking about protein tyrosine kinase inhibitors, or BTK inhibitors. Now, the first time I told a family member about BTK inhibitors, they said, oh, bind, torture, kill, which freaked me out. So I didn't know this, but apparently there was a serial killer named the BTK killer, which I was unaware of. And then I was forced to watch this very scary documentary. So I want to start by saying this has absolutely nothing to do with that scariness. Protein tyrosine kinase inhibitors are pills. And they're not new pills. These pills have been successfully used to treat lots of cancers. And it turns out that they look like they're going to be the next best thing in multiple sclerosis. And I want to talk for a few minutes about why I say that. So BTK inhibitors do some things that we've never been able to do before. I mentioned a second ago that treating B cells is a very effective way of treating MS. And when we give someone ocrelizumab, Ocrevus, or some of the other B cell depleters like rituximab or ublituximab or ufatumumab, these are words I did not make up, by the way, those deplete B cells. They knock down the B cells, they murder B cells, which is very, very effective. But because you're suppressing part of the immune system, there's an increased risk of infection. And so that's a risk benefit. Well, the BTK inhibitors don't murder B cells. They simply block B cell communication. So you don't murder the B cells, just plug in and say like, la, 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 I can't hear you. And in doing so, you can interrupt the B cell's function without increasing the risk significantly of infection. And so that's a really, really cool thing that I'm very excited about. The second thing that BTK inhibitors can do is they might be able to target smoldering MS. They might be able to target smoldering MS because they can do some things that we've never seen before. Interesting, all the MS medicines that we have today, so if I rattled off all 19, all the different formulations, they're all working in the bloodstream. None of them are crossing the blood-brain barrier, really. And MS is inside the blood-brain barrier. And these BTK inhibitors literally cross the blood-brain barrier and enter into the holiest of holies, the supercomputer that runs the body. And All of the current therapies that we have, all of them, target a part of the immune system called the adaptive immune system. So that's the B and the T cells. Those are the adaptive immune cells. There's an entire giant section of the immune system. It's actually bigger than the adaptive immune system, called the innate immune system. And up to now, we've never been able to target directly any of the innate immune cells, which is super frustrating. Excuse me, seltzer. It's super, super frustrating. Well, these BTK inhibitors, when they cross the blood-brain barrier, they can access these immune cells in the innate immune system called microglia. And microglia are innate immune cells, and when they get turned on and they get pissed off, they eat stuff, but they eat stuff they're not supposed to, like your brain. And they cause a nasty inflammation, and they definitely contribute to MS pathology. BTK inhibitors can turn them off. So right now, there are multiple MS manufacturers that are developed and testing these BTK inhibitors. So Sanofi has a BTK inhibitor called tolebrutinib. And at the Boster Center for MS, we are actively involved in clinical trials with Sanofi, looking at tolebrutinib for relapsing multiple sclerosis, primary progressive multiple sclerosis, and secondary progressive multiple sclerosis. So Genentech has developed a BTK inhibitor called fenebrutinib. And at the Boster Center, we're involved in clinical trials studying fenebrutinib in relapsing MS. There's several others. So Merck Serono has developed a BTK inhibitor called evobrutinib. And there's another one by Novartis called remibrutinib. And we're involved in some of those trials. And Biogen has even come out with a BTK inhibitor. And so it's very, very exciting to participate in MS research right now. And I'm so delighted that in Central Ohio, we've offered several Ohioans the opportunity to fight back and to participate in BTK inhibitor trials. So as I reflect, there are three things really that have me fired up about the future of MS. One of them is philosophical, and it's the paradigm shift towards a better understanding of smoldering MS and progression independent from relapse activity. The second is the development of a new biomarker. It's not prime time yet, but it's really exciting. And that's the NeuroFilament light chain that you can measure in the bloodstream. And that seems to correlate with aspects of disease inflammatory activity that are really relevant. And in the near term, it might help us monitor the disease better. And lastly, the development of a brand new class of medication, the BTK inhibitors, which can mechanistically do things we've never seen before, like blocking B-cell signaling without murder and crossing into the central compartment and turning off activated microglia. My name is Aaron Boster, and as always, thank you for learning about MS with me. I really appreciate the opportunity to share with you what's got me fired up and excited. And I'll now ask Stuart to come back on the camera so that we can open things up to a Q&A.
You got me, Doc. You got me. Thank you very much for doing this, though. Great. Awesome. Hey, everybody. There's a lot of people that signed on after I signed off earlier, so let me just tell you real brief. My name is Stuart Schultz, and I am president and founder of MS Views and News, and I am a peer to most of you, as I, too, have multiple sclerosis, which got this all started long ago. I met Dr. Boster, wow, about 10 years ago. Crazy story we had for what happened back then, but I'm not going to get into that right now. You'll just have to come to one of our other programs, and I'll re-explain it that time, unless Dr. B wants to take it away on that. But
I'll share this really quickly, that Stuart invited me to a program, and it was a live program. This is pre-COVID. You know, I had hair then, I think, some hair. And when I give a program, baby, you can't put baby in a corner. I don't like to be kept on stage. And Stuart, right before we went up, said, hey, listen, don't run around. And I laughed, and I jumped down off the stage, and I'm running around with my microphone. Well, the reason he said not to do that is because he was filming live, and he can't put patients on camera. So I didn't understand that. It was pretty darn funny. So baby had to go in the corner.
Baby had to go in the corner, back on the stage, and be quiet for a little while. So, and that's tough to get this guy to do, right? But he had to learn his lesson. He got punished. I'll say it like that. So anyway, though, you know, I've been working with Dr. Boster now for over 10 years, and we do a tremendous amount of programs together. And so for tonight, I wanted to bring him on board to, you know, to bring this information to you all. And yes, I want you to be involved. Now, Dr. Boster is not looking at your questions, is not looking at your comments. So if you have anything to say or ask, please type it into the question box, which is found by looking at the top of the scroll bar. You'll see that that red box with an arrow or rectangle, whatever, with an arrow in it. Just click on that and start typing whatever you want to type. I will read it all off to him. He's kept in the dark on this as well, okay? But so I might change some of your questions. Also, we took a lot of questions from people prior to the program beginning, and so I wanted to ask some of those here too, and so I will be ready to ask these questions. Like for starters, well, I'm going to go online first. So now, everybody, I'm going to say your first name. If you don't like it, too bad. I'm going to say it anyway, unless it's really, really odd, and then I won't say it because nobody really wants to know that their name is Alexander Gediddlehopper or something like that, you know. So I'm not going to say, by the way, you're not going to hear your last name. I'll say your first name. If you don't want it said, just type in something that don't say it and I won't say it, okay? Or maybe I will. All right. First one that's coming in online, Marla writes, how long before the BTK inhibitors will be available for us to try? And then she continues with, I have something, but I don't see, I have PPMS.
So Marla, that's a great question. And MS research is moving quickly, but it's never moving quick enough. Right now, the manufacturer that is probably leading the charge is Sirona with evobrutinib. And the other trials, the one that's just behind that, I believe, is tolebrutinib with Sanofi. And the Sanofi trials are still wrapping up enrollment. Now, these trials run for about 3 years. And I think it's probably going to be another 2 or 3 years before we get readouts on some of these medicines. And it's not right away that the FDA or the EMA will accept it. So realistically speaking, we're not talking about months, we're talking about a few years. But it's going to be way less than 8 years. It's probably going to be more like 3 to 5 years before they're commercially available. In the grand scheme of research, that's right around the corner, although emotionally, for many of us, myself included, that's too long.
Understandable. Thank you for that. Feeding off of that question, tell me what the differences are between the different BTKs and why there are so many.
So the differences right now are not fully understood. We know how the molecules are made. We know about the kinetics and dynamics, like the pharmacology of the molecules. For example, some of the molecules bind and they don't come off. That's called irreversible. Some of them are reversible. Some of them penetrate the central nervous system more, some of them do it less. But what we don't know yet is if that matters and what's better. And that's why we're doing clinical trials. Now, when you hear that lots of different manufacturers are studying this, it actually makes me very, very encouraged because some of the very brightest minds on the planet are in MS pharma companies studying and doing research. And when you hear that 5 or 6 of the biggest MS manufacturers are all chomping at the bit, they're either all dead wrong, which I doubt, or they're all on to something very, very exciting. And so just like it's wonderful to have options for B-cell depleters, for example, it's also really exciting that we're going to learn about the different BTK molecules. And as the clinical trials come about, you know, the old expression, the proof is in the pudding. The clinical trial data will teach us clinically and radiographically what those differences mean.
Okay, thank you for that. So since I asked for everybody to start sending in their questions, there are about 20 in front of me and more on beside me. All right, so the next one we'll take online again, and this is from Deborah. How do I get my neurologist to make the paradigm shift?
There's a couple different ways. You could say to your neurologist, hey, I just watched a webinar where they were talking about smoldering MS, and they were talking about progression independent from relapse activity. Is that something that you've heard much about? And just engage in a conversation. Another thing you could do is there's many research studies online, and if you're inclined, you could print one of those off and say, Doc, have you read this paper yet? At the risk of sounding self-aggrandizing, Stuart has videos on his YouTube channel, and I have videos on my YouTube channel, on this paradigm shift, on progression independent from relapse activity and smoldering MS. And you might say, Doc, there's a video that I would love for you to watch if you haven't seen it yet. See, you and your doctor are partners in your care. Your doctor reads some things that you didn't read, and you know more about you than anybody else, and it's a partnership. And so I think it's a fair thing to bring it up and have a conversation, absolutely.
Okay, thank you. There's a person online who, I won't say her name, but her name. She says, this chemist and biochemist is geeking out with your talk. I guess you're supposed to know who it is, so I'm not going to go any further with that. All right, next, Kay writes, I can't say this word, psilocybin.
Psilocybin.
Yes. Who?
Psilocybin.
Okay. Is it safe for MS patients?
So if you spend any time on the interwebs, you're gonna run into some discussions about magic mushrooms and about psilocybin is a naturally occurring hallucinogen. So back in the day, in the 60s, people would take hallucinogens and they'd have trips. And increasingly, we're starting to understand that psilocybin and things like that can be used to really help folks in psychiatry. So, for example, with refractory depression and for PTSD and stuff like that. There hasn't really been any significant research in the setting of multiple sclerosis. Now, here's my opinion. I don't think it's a good idea to go see Dealer Dan and get a hold of some magic mushrooms and then do an experiment in your living room. I do think that it's important to explore things like this in a controlled setting. So whereas I don't know if it's dangerous for MS patients, it hasn't really been studied just yet. I do think that it's a very exciting area of psychiatry, and I read that literature very carefully. So more to come.
There are people who are asking if you can have patients in different states outside of Ohio. Can you give an answer for that?
Sure. So, in the pandemic, the rules were made a little bit lax because we wanted to make sure that there was access to humans to get care. Now, after the pandemic has largely gotten under better control, the rules are back in place. And so the majority of my patients are in the Midwest and they come to travel to me. Because I have so many patients around the country, I have obtained what's called a compact medical license. And so if there are states that are participating in the compact medical license, I've applied for many of them. So I now have a license in Kentucky, Tennessee, Wisconsin, Illinois, Indiana. Not every state has a compact license. And so for patients where I have a compact license, they can come see me in clinic once or twice a year, and then I can extend new telemedicine visits. The bottom line is I don't think it's the best thing only to do telemedicine. And, I'm kind of old fashioned and I need to get my patients in my clinic in Columbus, Ohio, once or twice a year so I can lay hands on them. I can see them face to face. But for patients where I have a compact license, I can fill in the gaps with telemedicine in between, which is something I'm very proud of.
Great, thank you. Hey, by the way, I think that whether or not there's a compact license in the state of Florida, I think that you need to get licensed down here and come here like once every 2 months and spend a day and once every 2 months and never get to sleep during that day. And this way you could see everybody that wants to be seen at least for 15 minutes by you. Okay?
That'd be awesome. And Florida unfortunately doesn't offer a compact license.
I've got it. Well, you got to get through DeSantis first to get it. So, all right. All right. The next one, Angela is asking and saying, howdy, are there any trials with the NeuroFilament light chain labs?
So there is not a single modern MS trial that isn't measuring neurofilament light. Every single trial that we've talked about today, every single trial presently that's doing anything with MS is drawing blood to study neurofilament light. And so there aren't very many trials specifically looking at neurofilament light, but every trial is using it as a marker. And so any trial that you participate in that's studying a drug is measuring things, including NFL.
Great, thank you. Next, Darlene says, where can I read more and learn more about smoldering MS?
So there's a lot of different places where you can learn more about smoldering MS. I want to give a call out to a really great MS neurologist named Gavin Giovannoni. And Dr. G is an MS neurologist at Bart's MS out of London. and he's probably been one of the most vocal voices about smoldering MS. He has a blog. He writes a lot on his blog, and he's written many papers on the topic. If you are a science nerd like me, you can go to pubmed.gov, which is an index of every scientific paper that's been reviewed. And if you type in multiple sclerosis smoldering, you'll find several articles, scientific articles that have been written about the topic. You can go to MS Fusion News YouTube channel, or you can go to my YouTube channel, and we both have videos that we've made on the topic. So there's a lot of different places where you can learn more about it.
Great, thank you. And on our site, on our blog site, and was in our newsletter that just came out this week, there was an entire topic there on smoldering MS that is mainly for HCPs, but you know, people in the MS community are so smart that I think we could all be HCPs, right?
Absolutely.
Okay. Right. So, so I put it on our site so people could understand, and if they don't, they could contact their doctor. All right. Next, Sarah is writing, what are your thoughts of the Octave MSDA blood test and its use right now? My neuro is offering right now. Take it with a grain of salt or go for it.
So I think that at present, we need biomarkers. As I was sharing earlier, you know, right now we don't have a lot of biomarkers. Now, Octave is a company that is trying to develop a comprehensive battery of biomarkers. They're trying to come up with patient-reported outcome measures, special blood tests, and special MRI techniques with the goal of trying to inform us better about multiple sclerosis. I will share that it's a works in progress, and I am a little disappointed that a lot of the research hasn't yet been proven completely, but I don't think that it's a bad thing. I think that it's a good thing to be studying. And so if you have access to that, if it's free to you, if it's not going to cost you to reach into your pocketbook, and you are willing to contribute to research, I think that's a wonderful opportunity. And I think anything like Octave that is going to help us develop biomarkers is a really good effort.
Thank you. So tell us what the Octave blood test is actually looking for.
So it's a battery of tests, and it's kind of like their proprietary special sauce. So it's neurofilament light, it's GFAP, it's a bunch of different ones. And they have an idea that they think that they can kind of develop profiles of MS. It still works in progress. I don't think that it's been proven yet, but I think it's a really great effort. And I'm excited to kind of see how it shakes out.
Okay, but just bringing that a little bit further, is it looking to see what, I know it doesn't know yet, but is it eventually looking to see what your future course of multiple sclerosis looks like?
I think all of these biomarkers, no matter what flavor, shape, or size, are trying to help us predict the future in some way. And so I don't know that Octave has figured out exactly how to do that yet, but the goal would be to be able to draw a series of tests, get that tricorder out, and then to be able to inform the doctor and the patient about what's coming down the pike and how they might change it.
Okay, thank you. Going offline for a minute, tell us about artificial intelligence technology, or also known as AI technology. So much so is it, you know, showing up every day, and you know, when you say something online, all of a sudden you turn around and you're getting a zillion things of that sent to your phone and to your email. So how will this benefit those with MS?
So you think about advances in technology, which are very exciting. So for example, in my 20s, I got my first cell phone, right? And it was this big blocky thing, and it opened up and you could dial numbers, and it was like $1 million a minute to talk on it. And the reception was really bad. And that kind of phone is now in a museum because smartphones have become really, really exciting. So this gizmo right here is a computer. I can pull up translation on it. I can do math on it. It's got a calculator. It's unbelievable what these smartphones can do. And very few people in the world function day to day without their smartphone as like a technological aid. AI is different than that because AI is doing something that no technology has ever done. It's it's trying to do thinking. So it's actually trying to answer questions that we thought only humans could answer. So I think if you go back a couple years, many of us thought that the first artificial intelligence would replace blue-collar workers. You know, you'd have robots digging, construction sites and doing stuff like that. And that is not what's turned out. What we've seen with things like ChatGPT is that AI is starting to be able to predict and answer questions for us. Now, it's not perfect yet. Now, I have played around with AI a whole bunch personally. Some of you know that I make YouTube videos. And so it's really fun for me to go to the AI engine and ask it questions and see how dumb it is or see how right it is. And sometimes it's like 90% correct, which is pretty slick. I think that we're learning how to use AI to our advantage. And I think that it's a very exciting, and it's also a very scary technology. I will share an area where I have found it to be very, very successful. So as part of the practice at the Boster Center for MS, we get prior authorization for medicines to treat people with MS. So when we meet with you and we decide we're going to put you on a pill or a shot or an infusion, we have to apply to the insurance company to get approval. And sometimes it's approved and sometimes it's denied. So then we have to write an appeal letter. So I've taught my team to use the AI engine to help write the appeal letters. So you can tell the AI engine, this person is this age, they have these comorbid conditions, they've been on these drugs, they need this thing for these reasons, and the AI will help you draft a letter.
Very quickly.
Now, of course, the human has to read it and correct it and edit it, but I'm just giving an example where in my medical practice, we're starting to leverage AI technology to make decisions. Right. Do I think it's going to replace doctors? No, I really don't. Something that it might do is it might help us read an MRI better. I could see that happening in the near term. It's very exciting technology, and it's kind of fun to play with.
Okay, you stole a question of mine. So speaking about the AI technology, let's talk about icometrics and what they have for what they're doing with reading MRI right now.
Yep. So icometrics is one of a couple companies that are really leading the forefront of taking MRI reading to the next level. And one of the things that I'm most impressed is their efforts looking at measuring brain volume. So people impacted by MS risk having an accelerated brain shrinkage. Right? So to talk about that for a second, as you get older, you get shorter. So I used to be 6 feet tall, and now I'm a little shorter than that. I'm joking, but you do get shorter as you age, and your skin gets thinner as you age, and your brain actually shrinks. But it shrinks about 0.2% a year after the age of 18. In the setting of MS, that can be 10 times faster, which is really scary, because brain shrinkage correlates with long-term disability and with cognitive impairment, with functional reserve, and the traditional MRI can't measure brain volume. But softwares like the one that you're mentioning, softwares like NeuroQuant, these softwares are able to read the MRI and spit out brain volumes and compare it to normal, healthy controlled populations. Some of the other things that these exciting MRI computer programs can do is they can define lesions and measure the size of the lesion. And so they really are aiding neurologists in upping our game in interpreting MRIs. I use a software like that with every one of my brain MRIs, and it enhances my ability to read. And in specific, it gives me data about brain volume that I find really useful.
Okay, thank you. Going back online. A person, by the way, if anybody, if I read anything that was already asked and answered, just say ditto or just answer it quickly, okay? BTK inhibitors sound exciting, but how far along are we with remyelination meds for those whose disease have progressed for an uncomfortable level?
So remyelination therapies are farther behind than with BTK inhibitors. We've tried several that have fallen flat. Right now, I'm most excited about clemastine, but there isn't a lot of new information to share. I will share with you that it's an ongoing study. It's an ongoing effort. It's a big effort. And if I quote Yogi Berra, if we keep banging on the door, one day we're going to knock it down.
Wow, you know about baseball. Very
I
good.
know, I didn't know who that was. I just know that's some coach.
Okay, good. Yeah, he was a player. He was a catcher. Okay, and a coach and a manager. Okay, he did a little bit of everything. All right. I'm on Ocrevus. Ann, I think Ann. Yeah, I think Ann writes. I'm on Ocrevus for over 5 years now. Should I be changing medication?
So I can't really diagnose you or treat you on the interwebs. All I know is that your name may be Ann and that you're on a drug for 5 years. So I would say that I would stay on a drug unless one of 5 things happen. If you have attacks on the drug, it might not be working. If you have new MRI lesions on the drug, it might not be working. If you no longer tolerate the drug, then it might be important to think about switching. If the drug is no longer considered safe, and if your exam's getting worse, those are all reasons to have a discussion about switching. It doesn't mean you're going to switch, it just means that you need to have a discussion with your neurologist. Now, the other thing I'll say to you, Ann, is that safety and efficacy change over time. So something that's safe in 1 year, a couple years later, we have to reevaluate that risk benefit. And so I think that's a constant evaluation.
Okay, I messed up. It's not Ann. It's Amy.
Sorry,
Okay,
Amy.
sorry about that. All right, letters are too close together. Next, Matthew, truly. Matthew asks, would you take a BTK inhibitor along with your regular DMT?
We don't know yet, but I do want to tell you about a really exciting clinical trial. This is a phase 2 trial that we at the Boster Center for MS are participating in. And it's a trial by a manufacturer called Biogen. And in this trial, there's the first year, everyone in the trial takes a pill twice a day. They're either taking BTK inhibitor or Vumerity, which is an MS medicine. In the second year, it's combination therapy. And so there's going to be some people that are going to be on both. And so I think that as we do research like that, we're going to learn the answers to those questions. And we have now screened 2 patients who are going to be involved in that trial, and I'm very excited about that.
Thank you for that. Biogen's very brave. I remember what happened last time when 2 meds were being comboed together, right?
Yeah,
okay.
We have not had success trying to do this many times at all. But I think it's an important concept. You know, if you think about other diseases like oncology or infectious disease or even rheumatology, some of the biggest breakthroughs have come by combining medicines together. And so I think it's a worthwhile thing to keep trying.
Sure, thank you. Next, Lisa writes, my doctor said he'd like to put me on a BTK inhibitor July 24th. July of 2024. My eyes are getting bad. Time for new glasses. From what you're saying, it sounds like that might be a trial, correct?
I don't have enough information, but I don't think that July of 2024, the drugs will be out yet. And so that's definitely a question to ask the doctor.
Okay, thank you. Caroline writes, will these new therapies be used in patients that have had MS for over 20 to 25 years, or is it intended solely for newly diagnosed?
So one of the things that is amazing about current new MS clinical trials is we're starting to study people that have had the disease longer and people that their chronologic age is older. So I'll give you an example. There's a study called the CALPER trial that we're participating in at Boster Center. And this trial enrolls people, I want to say up into age 60. And it enrolls people who have had MS for quite some time. Increasingly, we're looking at clinical trials where people have primary progressive MS or secondary progressive MS without attacks. Previously, those folks were normally not invited to do trials. So I'm very excited that we're starting to look more deeply and genuinely at older age groups and at disease states as opposed to just early relapsing disease.
Great, thank you for that. And my next question for that was, are there any studies for MS patients over the age of 65 who are doing remarkably well, and to get them to be able to remain on their medications without their insurance companies trying to yank them off?
So fortunately in the United States, an insurance company can't take you off because of a certain age. That hasn't happened. I am aware that there are some neurologists that have developed a terrible disease called ageism, where they think just because you have a certain birthday, they should take you off their medicine. And that is infuriating. I think that's really, really not okay. That's an opinion, but it's my opinion. And so I think one of the ways that anyone with MS can contribute is by participating in a registry. So registries are an opportunity for someone living with a given condition to share their experience in a very formal fashion to educate. And so, for example, we're involved with a registry, actually several registries at the Boster Center. There are registries throughout the world. Many, many MS centers participate in these registries. And so if you are doing amazing, of course we would like to learn from you. And one of the things that I would encourage you to do is ask your MS neurologist or local academic center or MS center what registries are available, and are there some that I could participate in?
Okay, thank you. Well, I'll get into that later on. Okay, next person, Karina writes, could COVID have opened the door to MS getting through the blood-brain barrier? I was active 47, no visible disability until after COVID, January 21st. Now I have visible disability, drop foot, no clue. Please, everybody, before Dr. Boster even answers this, I have to ask again and again, please do not share what is wrong specifically with you, because he's not allowed to answer. And even if he's not your doctor, and if he was your doctor, he couldn't answer because then he'd be breaking HIPAA laws. So if you have a question, make it general. Make it about Peter and Paul or Jane and Joe, whoever. Okay, just make it very general. So let me ask this question again. Could COVID have opened the doors to MS getting through the blood-brain barrier?
I don't know if we know the answer just yet. I can tell you anecdotally, having treated people impacted by MS through COVID, that very commonly when people developed COVID, they didn't recover very well and they took a hit, and they ended up more disabled afterwards than beforehand. I also saw COVID trigger some people to have MS attacks. COVID is a nasty disease, but I still think that there's a lot of learning to be done, and I don't know if we know that answer.
Okay, what do you know about long COVID with MS and how people are handling it maybe still 2-3 years later?
So my mentor, Dr. Omar Khan, used to say all the time, sometimes nature is too generous. And someone can be saddled with multiple sclerosis and they can develop COVID, which can stick around, long COVID. And it's really adding insult to injury, because the number one symptom of long COVID is pathologic fatigue. The number one symptom of multiple sclerosis is pathologic fatigue. And it's a really significant barrier to try to overcome.
Okay, forgetting about COVID for a minute, how do people with MS react when they get the flu?
So anytime that your body is insulted, and I don't mean insulted like you're ugly, I mean insulted like you get an infection or you have a fever, your body tries to fight the fever off, and it activates your immune system to do that. That's what the immune system is supposed to do. It's supposed to fight off bad guys. And in the setting of MS, when your immune system gets revved up, you can short circuit. It can cause what's called a pseudo exacerbation, where you short circuit old damage. And sometimes, rarely, it can actually trigger an MS attack. And so it's important that we keep this in mind. If somebody presents to me with new neurological symptoms, the very first thing I do is I look for infection. The most common being a urinary tract infection, second most common being an upper respiratory tract infection. And if we identify those, we don't give them big gun steroids, we give them antibiotics to help them recover from the infection. Oftentimes we will then see the neurological symptoms ameliorate.
Great. Can you please remind people that their immune systems are ramped up and not deprived?
Yeah, so this is a really important point. People impacted by MS are not immunosuppressed. So if you have multiple sclerosis, your immune system is not suppressed, it's overly active. It's not uncommon that people with MS will say, I'm the only guy in my house that doesn't get sick, or I don't get sick as often as everyone else. Now, sometimes some of the most effective MS medicines that we use to treat MS suppress the immune system. So someone with MS can develop a scenario where they're immunosuppressed because of the medicine I'm giving them, but not because of the disease itself.
All right, next, we have Brad. Brad asks, can you have MS without oligon bands. 2 years
Oligoform
later,
band.
yeah, 2 years
So,
later, they think I have MS. Spinal Tap was negative twice.
so 90% of people with MS have changes on their spinal fluid, which means about 10% of people with MS do not. So you're not required to have bands to have MS. Although, if you don't have bands, you better be really, really sure that you have MS. Let me be more clear. If you have neurological symptoms that fit the description of multiple sclerosis, and you have exam findings, and you have MRI findings that meet criteria, you may not need spinal fluid to prove it. But if I have many patients where their MRI, their spinal fluid's negative, and they still have MS. So it is totally possible, but the vast majority of people with MS will have changes on their spinal fluid.
Right. Thank you for that. There are, and there have been people that have come to us over the years that have said that their doctors tell them that the medications that they're using are not doing a big enough job, and they want to know why their doctor would even say that based on that they're taking certain meds, and the doctor is saying that it's really not doing enough for you, and I really didn't want to put you on this, but you insisted, so I put you on it.
I have made a career, Stuart, of not guessing what other doctors think.
Sure.
And I certainly don't really understand that. I guess what I would say to you is, if you hired a plumber to put in a new sink, and the plumber started to argue with you about whether you needed a sink, or started to argue with you about where you chose to place the sink, you'd ask the plumber to leave and you'd get a different plumber. And doctors are no different. And so I am not for everyone, right? And some patients and we just don't mesh very well. And if you are not jiving, if you don't have a good therapeutic alliance with your doctor, find a different one. You want to find someone that clicks with you, that is willing to be a good listener for you and willing to be a partner in your care.
Very true. I interview doctors all the time. Next, so a lot of the MS medications, when they've lost their patent, it's because, well, they lost their patent, but there was a generic behind it to, for people to at least get on that generic if they were not moved to another medication. In Tysabri's case, they just lost their patent. There may be a biosimilar coming out, but there's no generic of Tysabri. What is the future for Tysabri to exist as it is now?
So this is a very advanced question. When a drug manufacturer creates a molecule, they create a drug, and they do clinical testing like we were talking about earlier today, and they bring that clinical testing to the American FDA or the European EMA, it gets approved, and it has a label, and it has a patent for a certain number of years, typically like 10 years. And during that 10 years, no other manufacturer is allowed to make that drug. So they have like the rights to that drug. After 10 years, they lose the patent and it can go generic. But some drugs they're not as easy to replicate. And whereas Gilenya has gone generic and now we have knockoff Gilenias, it's really hard to do that with a monoclonal antibody. Tysabri is a particular kind of medicine. And I don't know that you're going to see a generic Tysabri. So there's a manufacturer out there that starts with an S, and they are working on developing a biosimilar. Now, what's interesting with a biologic agent, a monoclonal antibody like Tysabri, is it's not the same rules to develop it. When you develop a generic of a small molecule like Gilenya, unfortunately, you don't have to test whether it works in humans. You just have to show the FDA that it's chemically very similar, which does not mean it works. But with a biosimilar, like a biologic agent, like the biosimilar for Tysabri, they actually had to do clinical trials in humans to prove that it works, which helps me feel a little bit more confident. One thing I'll say is that Tysabri first came out in 2004, and at the time it was hands down the very best medicine to treat MS ever, and it still is one of the very best medicines to treat MS ever. It's still one of the most effective drugs, and so I don't think you're going to see Tysabri go the way of the dodo bird. Having a biosimilar makes some people apprehensive, but if ultimately it makes it more available to folks, that may be a good thing.
Good. Thank you for that. All right, next person wants you to re-describe NFL, if you can, in a very short version.
So neurofilament light chain is part of the inside of the neuron. And when the neuron's damaged, it goes up. It goes up in the spinal fluid, it goes up in the blood. And in the setting of MS, when the disease is more active, neurofilament is elevated. And when the disease is less active, it goes lower. And so we're trying to develop a way that you can do a blood test to measure neurofilament light to help give us insight into MS. And it's not perfectly sorted out yet, but it's getting close.
Is that anything similar to Krieger's leaky pool?
So Stephen Krieger, who is a friend of mine and a brilliant MS neurologist, he also is more bald than I am. I just want to point that out. He's at Mount Sinai in New York. His contribution to MS is phenomenal. And one of the most amazing things he did is he developed a philosophical concept of MS called the topographical model of MS, or I sometimes call it the leaky pool model of MS. And I am a student of Stephen's work. I love the leaky pool model, and I use it a lot when I teach people impacted by MS. And smoldering MS can be explained with the leaky pool model because the amount of water in the pool represents the functional reserve in the brain volume. And the way the water is draining over time from the pool is a reflection, in some respects, of this smoldering concept of multiple sclerosis, at least in my opinion. So the leaky pool model is really, really cool. Good job, Dr. Krieger.
Exactly. Thank you very much. Next, Ruth writes, can a person volunteer for a clinical trial and is age limiting a limiting factor? You can blame this, everybody, on my medications I'm taking for my leg, all right? Well, you don't know about it, so that's another story.
So yes, you can volunteer for a clinical trial. You know, some people they're fine treating their disease, which is awesome. But some people, that's not enough, and they want to stick it to the disease. And one of the best ways to stick it to the disease is to volunteer to fight back in the context of doing a clinical trial. So if you're willing to consider a clinical trial, God bless you. I think that's amazing. You know, if it wasn't for people like you that were willing to consider a clinical trial, we'd have zero drugs to offer people with MS. And so we have to give thanks to all the people with MS that came before us that volunteered for those trials. Now, trials have age cutoffs. So the trials used to all be from 18 to 55. And now, as I shared, we're starting to extend that age. And so one of the things you can do is you can go to clinicaltrials.gov. So that's a website by the American government. And every clinical trial is registered there. And you can type in multiple sclerosis, and it'll give you a list of all the clinical trials. Or you can ask your local MS Society chapter or your local MS neurologist, what are the trials in my area?
Sure. Thank you. All right, Kay writes, how do we get clemastine?
Clemastine is, it's actually an antihistamine, but we're studying it in MS right now. So, you know, your doctor can write you for clemastine, but I'm not recommending that because we don't know enough about it or the dosing, et cetera, et cetera. But I think it's probably one of the more exciting potential options for remyelination.
Right, thank you. So our friend in the UK tells me that that's a pretty active ingredient over there, clemastine, that doctors do use it on patients.
I don't know exactly what goes on across the pond, and I'm delighted to hear that. But that's news to me from this, from this American treater.
Okay, thank you. Next, Merle writes, do you think it's a good idea to get annual vaccinations while on Ocrevus?
Yes.
Okay, great for that. Next, we have Sarah. Could you mention again slowly the pharma companies and the med names for the BTK inhibitors you were talking about? They all blurred together when you said them earlier, but let me let everybody know that's online that this program is being recorded, so you can slow it up and listen to it many times. And you can hit stop, pause, play, reverse, rewind, or etc., so you could spell it all out. This program will be online in less than 30 days.
So this program that we're doing is being sponsored right now by two MS manufacturers. So let's talk about them first. So Sanofi is an MS manufacturer, and they're studying a BTK inhibitor called tolebrutinib, T-O-L-E-brutinib. And they're studying it in several clinical trials that we're participating in at the Boster Center, including the Gemini trials for relapsing MS, including Hercules, which is a secondary progressive MS trial, and also Perseus, which is a primary progressive MS trial. And all of those are tolebrutinib, and those are by Sanofi. This talk tonight is also sponsored by another MS manufacturer, Genentech. And Genentech has a drug that they're studying called fenobrutinib, F-E-N-E-brutinib, fenobrutinib. And at the Boster Center, we're actively enrolling for FENHANCE is the name of that trial. And so those are two of the many manufacturers that are developing BTK inhibitors. There's another manufacturer called Serono, and they have a drug called evobrutinib. And there's a manufacturer, Novartis, that has a drug called remibrutinib. And those are all the phase 3 trials. And then there's some earlier trials that companies like Biogen are getting involved in.
Okay, thank you for that. Next, a person named Jill writes, was it the presence of NFL in spinal fluid taken during a spinal tap the same as NFL being investigated now?
Yes. So we've known that you could measure it in the spinal fluid, and it's actually like 42 times better, higher concentrated in the spinal fluid. Remember, I made mention to Bart's MS, which is a big MS center in London. They will do lumbar punctures a couple times a year in patients that volunteer to measure BTK, or excuse me, neurofilament light levels.
Is there a thing as atypical? Is there a thing called atypical MS? Can you have it and not meet the McDonald criteria?
So the word atypical just means that it's not like most of the others. And anyone that's done MS for a while may see cases of multiple sclerosis that are a little bit unusual. I think it's really important when we're trying to diagnose MS to live and die by the diagnostic criteria. And the reason I say that is sometimes people get misdiagnosed. And so if you meet the diagnostic criteria for MS, you're much more likely to ensure that you actually have the condition. And that's really important because every medicine we've talked about has side effects and risk. And so it's a travesty if someone's being mistreated. If you have an atypical case of what might be MS, you better be in the hands of an expert world leader in diagnosing MS and making sure that it really, really is that. It's very, very important.
Okay, thank you. There's a person that's online right now from New Zealand, and she has a question for you that I hope doesn't upset you, but I'm going to ask it anyway. Howdy, Dr. Boster from New Zealand. Wonder what you thought of Gavin G's view that MS is not autoimmune, and it's actually being driven by Epstein-Barr virus.
So Dr. Giovannoni, that's been a theme. We've talked about him a couple times tonight, right? Because he's done a lot for the concept of smoldering MS. And so he's not saying it's not autoimmune. What he's talking about is what causes multiple sclerosis, right? And so those two concepts are not in counterpoint. So we've known for a long time that the immune system misbehaves in MS. And one of the things that's becoming increasingly clear is that may be caused because our body sees EBV, mononucleosis, and builds an arsenal, an immune arsenal against it. And that immune arsenal by accident can identify our brain as EBV, mono, and attacks our brain thinking it's attacking the virus. And so we've had books written about EBV and MS going back to when I was a fellow and had a full head of hair and no beard. And recently, we've really come forward with better and more robust information suggesting that really is an important aspect to leading to development of multiple sclerosis.
Okay, thank you very much. By the way, everybody, we had 110 people online tonight. I want to thank you all for being there. And I have one more question to ask you, aside from the many that are giving you the kudos that you deserve. And I'm not going to read them all off one by one, other than to say there were many giving you kudos, okay?
Thank you.
Kay writes, are measures of brain atrophy currently being done outside of studies?
Yes, so iotrometrics that you were talking about, I use a different software called NeuroQuant. It's being done routine in clinical practice. So every brain MRI I get, I measure brain volume. Absolutely.
I'm going to say goodnight to everybody, okay? Thank you.
Thank you, guys. Stuart and MS Views and News, again, thank you for the opportunity. For the 110 of you that took time out of your evening to up your game and ask brilliant questions, thank you very much. As always, my name's Aaron Boster, and thank you for learning about MS with me. Check me out on the interwebs. Go to my YouTube channel, Aaron Boster MD, or you can find me on Twitter, which is now called X, or Facebook under the same handle. Take care and good night, everyone. Be safe.
Good night.